It gives me great pleasure to welcome you all to another one of our expert-led series. And today I am joined by Dr. Amal Hassan, who is a sports and exercise medicine consultant. And she has a special interest in female athlete health. And so in her private practice, Amal sees girls and women across the lifespan for health injuries or issues relating to sports and exercise participation and performance in women's health. So she's the team doctor at Harlequins women's team and has spent time as the school physician at the Royal Ballet School and leads the FIFA Perinatal Research Group. So she is so passionate about advocating for female-specific health considerations being properly considered in sports, exercise, and medicine. And supporting active girls and women in accessing the help they need. So it is amazing to have you with us because obviously we are just totally aligned in our dedications, but differing in our specialities. So for anyone who doesn't know me, I am Dr. Helen O'Neill and I am the CEO and founder of Hertility, but I'm also a lecturer in reproductive and molecular genetics, where I lecture both masters and medical students in reproductive science and women's health and pre-implantation genetics. And so I have a special interest in genetics, but have spent the last few years building Hertility to really try and bring some of the things that we know that are in the textbooks but can't really apply them, and to really just bring answers into our own hands. I as a woman, not just a scientist, but as a woman, really wanted answers about my body and my menstrual cycles and my hormones because I knew the fundamental role they played, and yet really just couldn't get easy, accessible answers. As many of you will know, the current barriers to entry when it comes to accessing information about any conditions, any hormones, really are dependent on you either suffering, having a condition, actively trying to conceive, having multiple miscarriages. And actually, not only are the barriers to entry prohibitive for just finding out about your overall health, they're actually a little bit barbaric. So that's both in terms of like NHS referrals. We are in a dire state when it comes to the NHS, unfortunately, because all gynecology clinics were closed over COVID. And that meant that all gynecology clinics were closed because they were considered non-essential. So there are now close to 700,000 women on a wait list just to see a gynecologist. So the work that we're doing is all the more important in streamlining women to the care they deserve. So I'm going to give a small, we're gonna top and tail this talk. It's going to be quite informal. We're going to have chats. We'll take questions at the end. Both of us lecture for a living and research for a living, so get out your pen and paper, take some notes. We will treat you like our students, but we also know that you guys are already experts. So this is something that we really just want to be able to enhance your knowledge about your bodies and to be able to answer some questions. So hold on, am I sharing now? Okay, so just to make a start, as I mentioned, I'll just give an introduction to what we do, Hertility, and a little bit about the menstrual cycle, and then Amal is going to take over in terms of the more specialist sports and movement. And actually, it's going to be quite conversational as well. So just a word of what Hertility is for anyone who doesn't know. As I mentioned, we've spent many years building an algorithm that helps us to predict whether the combination of symptoms that you have or menstrual cycle disturbances that you might have, or just even patterns, could be linked with a reproductive pathology. So that has been many years of research and in the making to create a health assessment that enables us to determine what's an appropriate panel of bloods that we should test you for. So the Hertility pathway works to essentially ask you all of the relevant questions pertaining to a particular diagnosis. It may be that you have nothing wrong with you, but we need to make sure that we can rule everything out. So the online health assessment that you will do will ask questions about your menstrual cycle, your symptoms, your previous medical history, and your lifestyle as well, because that plays a big role. And then from that, we actually then will assign you a bespoke panel of hormones that's appropriate to determine whether you have something wrong. Now, as a standard, everyone will have their thyroid, menstrual cycle hormones, their ovarian reserve markers, measured, but should you trigger that you have a suspected diagnosis for anything else that we can confirm with additional analytes, that's what we'll do. So from then you'll get a report. So it's an at-home blood test. From then you'll get a report. We have currently coded over 54,000 clinical scenarios, so that essentially the report will tell you all of the things that, all of the combination of your symptoms plus your blood results and what they mean in combination with each other. And why this is important is because when you see all of our regulations down the bottom, those are very difficult to get and you need to work extra hard to get them. There are many blood testing companies out there, but none of them, they're just screening companies. They can give you a blood result, but they cannot extrapolate what that blood result means, certainly in the context of your symptoms or anything else that you've told. They also cannot diagnose. So we can not only screen, but we can treat, diagnose, and prescribe, and we take that honor and privilege very seriously. So we provide a full range of clinical services, from telemedicine services with our gynecologists, which could be fertility, gynecology, endocrinology, nutrition, hopefully sports one day, and then equally treatments. So we refer for IVF, egg freezing, ultrasound scans. We have a full network of clinics across the UK, and we can do prescriptions and HRT. So we really are trying to essentially recreate the clinical experience. What we now know and expect from routine online transactions is that we can lie in our beds, order something trivial, and it will arrive in Amazon style the next day. I'm often quite apologetic when I open the door and I realize my Amazon delivery has come already and it's something very unneeded. And then I can't believe that the same standard doesn't exist for real life matters like our health. So that's really what we're trying to do, is create something as instant and expert as possible when it comes to our reproductive health. So that is just a little bit of a summary about Hertility and what we do and what we offer. So we're just going to cover some of these over this. It may sound a little bit basic to say that we're going to cover the menstrual cycle and how it's controlled, but we do feel it's important to have an ode to the menstrual cycle, because when you see the level of fluctuation, you're going to really realize, in terms of the menstrual cycle and the ovarian and uterine cycle, how much physiological, endocrinological change is happening within the space of a week, 2 weeks, 3 weeks, and 4 weeks every single month. And the effect that they have on our muscles and tissue and bone, and the elevated injury risk that you can have at certain points during your menstrual cycle, and then a little bit about contraception as well. So hopefully at the end of this, you're all going to be experts and we won't need to do our jobs anymore. So just starting with the menstrual cycle, obviously the basics are that you will have about 400 to 500 periods in your lifetime, which is a lot of time to spend bleeding, in the absence of fully understanding and appreciating what this cycle is doing. And the reason we kind of put some of the stats around how long it lasts is that really anything outside of the average length is something that you should be getting help for. So we usually say that you look for how you bleed, how long you bleed, how much you bleed, and any of the symptoms surrounding that. What's interesting is that the average age to start your period used to be around 12 years old. We now see that the average ages are really changing in certain locations across the world. Some places they have an average age of 8 years old for age of menarche, which is when your period starts. So it stands to reason, actually, the reason I bring that up is that while we have this textbook figure and number of 51 years old, which is the average age to start menopause, actually what we're witnessing from our huge database is that the onset of menopause and perimenopause, the symptoms, is happening much earlier. So being aware of where you are in your reproductive lifespan is very important, because the statistics are definitely changing. And I show this with no other reason than to really give you an appreciation of the level of control of the menstrual cycle, how it's controlled by multiple organs, our hypothalamus, our pituitary, our ovaries themselves, and all of these are quite interdependent. in terms of the hormones that are produced, that are in red here, that are both antagonized and agonized. So it really shows you if one thing is off or is disturbed or is upset, it really can affect the entire pathway. So this is really more of an ode to the complexity and how important it is for us to really understand our external experiences and stresses that can actually impact this cycle. Okay, so just again, looking at this as a graph, ordinarily, this is the graph that nobody understands. It is constantly being presented, correct, Amal? And nobody comes away with a real appreciation. The only thing I really want everyone to actually just gain an appreciation for in this is that we have the different phases of our menstrual cycle. This is indicating a full month. But what I really want you to look at is the 4 different hormones here at the bottom are very powerful hormones. And what's more is that you can see such a huge difference between this and this. I always say it's a bit like the difference between night and day. If I was to ask you to do an exercise that required, a work, you have to write an essay. You're back in school now. You have to write an essay, but you have to do this between the hours of 3 and 6 in the morning. You would say, it's going to be the middle of the night. I'm not going to really be feeling myself. I'm going to be exhausted. I need to prepare for that. And yet the difference in our melatonin between day and night is probably not as substantial as the difference between estrogen here in the midpoint of your cycle around ovulation and here at the luteal phase. So accounting for and acknowledging the time that you are at, or the stage that you're at within your menstrual cycle, is really important. And then looking inside your body, equally realizing, look at, this is essentially the lining of your womb, so your uterus, and looking at how much change is happening in those days. So these are really just key indicators to say, if we can recognize such a huge physiological difference and hormonal difference in even on a screen, then surely we can recognize that this is going to have a massive impact on our day-to-day. So I'm going to hand over to Amal now, because you are much more adept at knowing what is normal, what is not normal. And really, again, you'll notice that we have anatomy throughout, just to show everyone how much we have crammed between our hips, both in terms of our uterus and our bladder and our ovaries, and the unique interaction that's happening. So I will pass over to you.
Thank you, Helen. Good evening, everybody. I cannot believe the number of people that are on this call. So it's a real pleasure to virtually be with you, if not see who you are and say nice to meet you face to face. This can be considered as quite basic. Some of you might think you're pretty set with your knowledge around the menstrual cycle. But it's really amazing how many people don't actually know that much about the menstrual cycle. And even in using those terms, we mean so much more than just a period or menstruation, that bleeding phase. We absolutely do mean that entire process and that cycle with that lovely visual that Helen presented, that as a textbook duration is taught to us, might last roughly 28 days. And a lot of us take that as being normal. And actually, normal is quite variable, and normal can vary even within an individual. So from one menstrual cycle to another. A cycle is essentially day 1 of your period to day 1 of the next period. And I would say not a great deal of research has actually gone into determining this range that we get presented with. Beyond the 28 days of, say, an average, is this 21 days minimum to potentially 35 days maximum duration of a normal menstrual cycle in an adult. If you've had a period for at least 5 years, this would be the duration of a cycle that we would say is normal. But actually, if you've been menstruating for less than 5 years, that that top end of normal would push to something like 40 days, whilst your hormonal axis is maturing. Periods normally last anything between 2 to 7 days. You'll know that they can even vary from cycle to cycle. The flow, the symptoms related to the period phase of your menstrual cycle. And actually, you can have symptoms at any point of the menstrual cycle, very much related to those peaks and troughs of those hormones that Helen was presenting about. Absolutely, your cycle length can change over time. I don't know if anyone remembers or is in their adolescence right now, but initially, as your hormonal axis is maturing, your cycles might be a little bit irregular. They could be quite spaced out before they get going. And then approaching perimenopause towards the menopause, your cycle length with age actually can elongate. And we know that factors that can influence cycle length include age. They also include your smoking status, alcohol, as other examples, and of course, exercise. But that is normal. So that elongation with age is normal. I think it's remarkable how much blood we do actually lose on a period. I think sometimes it can appear that you bleed quite a lot. And to some people, losing between 30 to 60 mils of blood during that entire 2 to 7 day period could be really surprising. To others, maybe not. But of course, there are individuals who will struggle with very heavy bleeding. And of course, that's subjective, and it's subjective as to how that impacts you. But generally speaking, heavy bleeding would be considered the sort of regular hourly changing of a tampon or a pad, having to double up on your period products, regularly flooding through your period products, and essentially being inconvenienced and distressed by it. That is also really important. So I've already moved on to that bit, sorry.
I shouldn't be in control of the slides. But
No, it's all fine. I was going to mention clots because of course, clots can be sometimes quite painful to pass through the cervix, and also quite alarming to see. But they are also a feature alongside heavy bleeding. They might of course be accompanying that experience as well. So you did mention that on the slide too.
Okay, I skipped straight ahead to estrogen.
No worries.
Because estrogen is my favorite.
You get
And
to
the
estrogen, that's
underrated
fine.
of all chemicals. So let's talk a little bit about estrogen, because it plays such a fundamental role. And yet when you ask people about estrogen, usually they think of it as, sure, a female hormone, absolutely something that is going to, I'm a little, my estrogen is too high, almost negatively. And it's almost therefore seen as something a little bit weaker. And actually, estrogen is so much more powerful beyond our reproductive cycles. It controls our neurocognitive health, it controls our bone health, it controls our skin and elasticity, it controls our menstrual health, sure, but there's so much more of a fundamental role that it plays. I always find it really fascinating that if somebody undergoes a hysterectomy, so their womb if their ovaries are removed and they are not given estrogen to replace, within a year they have osteoporosis. So it's incredible the impact that estrogen plays on our bone health, and yet so few of us really do take time to recognize that. And when many people over exercise, they tend to say that it's actually quite handy because their periods go, and they're not realizing the role that it actually is having on their overall cardiovascular health, cognitive health, but also bone health.
Yeah, this is a really important point. By the way, not to gloss over all the questions that are coming through in
No,
the
we'll
chat.
get to them at the end, don't
Yeah,
worry.
I just wanted to reassure everybody we're not ignoring you.
No, we'll get to them at the
We will
end.
absolutely get to them. And Helen, it is being recorded, isn't it? In case
Yeah.
people have missed the beginning. Okay. So this is a large part of my work, I guess. So Helen mentioned that I worked at the Royal Ballet School, and at the Royal Ballet School, of course, we're seeing a lot of kids who are doing a lot of dance and general activity, and they're growing, and their menstrual cycles are being established, so that kind of function is establishing as well. And we see even in the younger age groups, so not even just at the perimenopausal end or the phase of life where somebody might be more commonly having a hysterectomy, or their ovaries removed, struggling with that estrogen availability, to essentially build that bone stock in adolescence. And I think that's a really interesting fact that some people haven't necessarily grasped or ever been taught. But as women, we lay down 90% of our bone stock by the age of roughly 19. So we put all that money in the bank in terms of our bone strength, or bone mass. And in our 20s and 30s, before the typical age of menopause, when estrogen levels, of course, plummet, we're in this game of maintaining our bone stock. And estrogen is so protective of our bone stock, but it's absolutely so responsive to any reduction of hormonal stimulation from those pathways above. So in that visual that you presented earlier, with the brain speaking to the ovaries, and those hormones speaking and signaling to the ovaries to ovulate and have that production of estrogen, if that pathway is suppressed, and reasons for suppression of that pathway might include large exercise volumes, but in the absence of the quantity of nutrition required to match that energy demand and even surpass it, because our body has more need for energy than just the exercise that we're doing. And this hormonal pathway is one of those examples. In those scenarios, if your estrogen levels reduce because you aren't ovulating, because your body doesn't have enough energy to ovulate, your bones will suffer. And the reason being that estrogen helps balance this very active balancing act of bone formation and what we call bone resorption. So the cleaning up of sort of old and used bone, and the laying down of new bone cells and matrix. And this is an active day-to-day process. Usually exercise is really protective of that, and really supports the building and maintenance of bone stock. Without exercise, without weight-bearing activity, you also get reduction in your bone mass. And you might know that from cyclists who typically don't do a lot of loading exercise and stay lean. Even in those cases, bone mineral density can reduce. But it's also an anabolic hormone, isn't it, estrogen? So it builds muscle. Muscle is protective of bone. It keeps you fit. It stops you falling in your old age. It's very metabolically active, so it helps in maintaining lean muscle mass. And it's brilliant for your neuromuscular function. You can feel really zappy and just generally your fittest. It's beyond this great for endurance activity as well. So for your cardiovascular function through endurance activity, but even that kind of low intensity, multiple muscle contraction, sort of low intensity strength work, and also high intensity because it's anabolic. So many benefits throughout gut health, as you say, all connective tissue, but probably way and beyond what we can even understand, because of course that limitation in terms of the research not being particularly focused on female athletes or female exercisers. There's that statistic, which I'm sure will be updated soon, that 6% of sport science and medicine research is done on women. So
Just 6%.
just, you know, six, the token
6%.
six.
Everything else is done on men. It's probably indicative of, actually, it's probably even worse for just general pharmacology. Everything, all research is done
Absolutely.
is done on men. I
Absolutely.
think that was the most horrific eye opener when I wanted to start building Hertility and trying to work to build predictive algorithms for different what your risk factors were, and saying, right, let's go back to the data, what data is out there, and just saying like, oh my God,
Mm.
how are clinic guidelines set on such poor data sets? So really just thinking like we need to build this ourselves, and so that's why I think everything we do is a research effort and is contributing to the research.
Absolutely.
My strange, I guess, analogy for the importance of weight bearing exercise for our bone health as well is um, thinking about astronauts when they're in space. They are
Yeah.
given rigorous exercise and training programs, because if you don't have load bearing exercises, the cells that are in your bones will not form. Like it's like they require pressure makes diamonds. Well,
Yeah.
pressure makes bone cells as well. And in
Yeah.
the absence of having that pressure, you do lose that really important additional scaffolding within your bones. So thinking of it less in terms of generic advice around movement and weight bearing exercises, and more around a real mechanical entity that's needed, I think is quite helpful in terms of saying, right, why do I need to move at all?
Yeah.
Um,
Bring it back to those basics.
we ain't going to space, but
Yeah.
we definitely need a little bit
Need to get up.
more to reduce the number of microfractures or anything like this. And actually, to this point, these three areas here, which are quite, there's a lot here, but the fact that estrogen plays a role in our bone and our skeletal muscle and our connective tissue really shows you that if you are lacking in this, I met a former colleague of mine, an avid runner, and she said to me, she's an incredible athlete, but she said to me that, going through perimenopause, she could just kind of sense things, but she said, I actually have not really felt myself at all for the longest time. And she runs every day and she's got her Garmin. And she said she approached the doctor about going on HRT or finding something. She said, I just don't really feel right, and was not prescribed. And then a year later was prescribed. And her first run that she did, she said, I was running 20 seconds per mile faster than I've ever run in my life. So she was like,
Oh, wow.
this literally transformed. She's now, oh, she's looking back saying, I actually regret a lot of my life wondering whether I actually was always subpar because I was perpetually deficient in estrogen.
So
And I
that's a
put it
really
in.
important point, because that's a really sensitive marker. And perhaps at the elite level, we might have that performance data that suggests what your peak performance should look like. Um, but I think someone's trying to get in this room.
That's okay.
But the general population won't have, like I said, the 6% of research is not done on only 6% is done on female
Yeah.
athletes and women exercisers. So we don't have those performance metrics of what a normal female runner looks like, and what that performance should look and feel like. But it is it's elusive.
Yeah.
But any change you will be so sensitive to that, and I often will investigate hormonal levels in clinic in somebody who just feels like their performance is changing and they can't quite think why. Their programming hasn't changed, they're
Yeah.
doing all the right things. That's when we'll start looking into it. There is a question around, what can you do if your estrogen is low? And of course, that is case specific, because there are many reasons why estrogen might be low. But
Yeah.
in those cases where exercise volumes or particularly exercise volumes are a cause, or perimenopause, sometimes it is lifestyle related, sometimes it's pulling
Oh,
back.
even dietary effects
Yeah.
can really alter your estrogen levels. I always say to, sometimes people say to me like, there's nothing wrong with me, I don't need to test. And the most annoying is when they say to me, I'm not interested in having children, so I don't need to have a test. And I'm like, you need to know what your hormones are doing. 67% of people who've ever done a test with fertility have at least one out of range hormone. And this is reflected in global statistics and global data. The number one prescribed drug in the world is thyroxine for thyroid imbalance. So we know the prevalence of hormone related conditions globally, and yet the majority of people don't know what their hormones are doing. And I always say it is far better to know what your hormones are at when you feel good, because you know what your baseline is, you know what your gold standard is. And so when you have this, we tend to have really wide reference ranges. So you could really fall anywhere on the higher end, anywhere on the lower end. But if you're somebody who's as a baseline on the higher end and you dip a little bit below the lower end, you're going to feel it. And unless you have that reference point for what is your normal, you're still going to be considered within the normal range. But for
Yeah,
you,
trends are
you
very
it's different.
powerful, and often, things don't go from being normal to absolutely the opposite overnight. The function of hormonal production generally means that if you are going to develop some sort of a problem, and there is an association with a change in the hormone levels
Yeah.
that you produce, there will be a trend over time. So it is, you're right, it's useful.
Track your ovaries over your calories is our motto.
Oh, nice.
Okay, do you want to talk a little bit about injury risk? Because there's been a lot in the newspaper about this. I don't know whether you're going to be happy. Oh, I've started again for some.
I
Sorry.
I have a very tempered response to this question. Or
Right.
this is everywhere. If you're a sports fan, particularly if you follow women's football, the hoo-ha in the press around ACL rates at the moment in particular, you can't get away from it. It seems like at least one a month, maybe more reported in the media. So the issue is female athletes typically have not been conditioned throughout their adolescence and early 20s in a way that their male counterpart may have. So if you take the case of football, academy football in the men's game is established. It is so established that they follow this concept called the long-term athletic development plan. They get so technical that through the growth phase, they plot growth, the rate of growth. They will change training exposures for young male athletes, as they should, around peak growth phases. I don't know if any of you have heard of biobanding, but essentially the biologically younger boys will train with biologically similar boys. And if you're a sort of early maturer, you will have an opportunity to train with bigger kids. And it's the load that they have been exposed to and the specificity of training over time far outweighs what any female counterpart in, say, football has been exposed to. So when you consider the professionalization of women's sport, the tournament calendars, the match load, I find it's unsurprising that we are seeing these injuries where load and your historic exposure to training, which we call your training age. How mature are you as an athlete? How much adaptation in response to training exposures have you had over time? To me, that is a much more interesting risk factor and relevant risk factor than the hormonal milieu or the hormonal considerations. And that's not to say there isn't necessarily a hormonal consideration. But if we're talking generically across the board, I think it's more training age related and related to the sort of rapid increase in their match exposure at the professional level. When it comes to the menstrual cycle and hormonal contraceptive use, for example, and how that might relate to injury risk, we do have some studies. Yes, okay, Dan Martin's study. I'm not going to read what's on the screen, but essentially from what we know, you're looking at either that kind of mid-follicular pre-ovulatory phase of the menstrual cycle where the LH spikes, and then you're looking at that luteal phase, so the second half of the cycle, potentially around the mid-luteal phase, where your progesterone is coming up if you've ovulated, and your estrogen levels are also rising a little bit, but not as dramatically. And it seems like they are the most likely phase points that an athlete might suffer an injury. The mechanism explaining this hormonally can be quite tricky because sometimes it doesn't fit with the science. And so that's where you've got a huge camp of scientists who are coming out and just absolutely refuting that this is a relevant factor. Most of us are reasonably calm and will consider that, you know, for some people, the menstrual cycle is likely to be impactful in some way. But what we don't know is how. And we just have speculation at the moment that the theories are not solid. We also don't have great numbers. So what we really need is massive data. And if you imagine UEFA, for example, are an example of a group who can collect really good data, but what they're not doing is collecting menstrual cycle related data, which is actually quite hard science if you want to get it really, really accurate. As we mentioned earlier on,
I know we do it.
there's so much
very
variance.
excited
Yeah,
for us
you'll do it.
to launch our app in the summer. When we have our app, we'll have ongoing, you know, symptom management, menstrual cycle data, and then we'll really be able to start sewing with thread.
There is, I will add, there is definitely a little bit more evidence, and that's been recently published, looking at injury risk pertaining to muscle injuries specifically, so not necessarily ligament injuries like ACL tears. Muscle injuries are really common, though, like calf tears, hamstring tears, quad tears, in female athletes. Again, load related, load exposure, training age related, but menstrual cycle related as well because of the connective tissue elements. So summary, it is one factor. There are a million other factors that I haven't even mentioned. Injury is very complicated, multifactorial, but there are some big hitting risks. Whether this is one of them, we're still investigating it.
Okay. Exciting. Right. Well, let's talk about low estrogen, maybe an injury risk, and more like around REDS. I know this is one of your areas of expertise. Do you want to explain to everyone what REDS is?
Yeah, so I'm just going to repeat that concept that I explained before around energy availability. Basically, when it relates to exercise, we eat, and that might be measured what we eat in calories. We expend energy related to exercise, and we can calculate that similarly. And we can take away the amount we expend exercising from what we've put in the bank, what we've eaten. I'm going to be a bit technical, but the more lean you are, the more energy you burn. So in terms of lean muscle mass, but that essentially, after all of that has been calculated, you are left over. You have a sum of energy left over, and that energy is then spent on all of your body's physiological processes. Even sitting and doing not very much, you will burn energy. There's so much going on in our bodies related to all of these pathways on the screen. We're metabolically active even when we sleep, digesting, sort of that processing of nutrients, cardiovascularly, in order to sit, in order to breathe, in order to be alive. So much is going on. We need energy for that. And REDS, or as it's now, it used to be female athlete triad, it's expanded to REDS because we've acknowledged that actually this energy deficit can impact any area of the body or function of the body, and it can also affect men, not just women. So relative energy deficiency in sport is what it's called. If you have this energy deficit as an exerciser or an athlete, the way it might present is irregularity of your menstrual cycle initially if you're not on hormonal contraception, and then an absence of menstruation. And this can, stop, start. It can delay the start of your menstrual cycle. If you're an adolescent athlete at high volume and you're not quite meeting your energy demands nutritionally, and you're growing as well, which is hugely energy demanding. And I often see this present in clinic as a bone stress injury. So we've already talked about bone and the vital importance of estrogen in bone physiology. If you remember, estrogen really supports that balance between the creation of bone cells and matrix and the sort of clearing away of that which isn't great quality bone, and that's really active every day. In the absence of estrogen, what happens is you're not creating enough to match the clearing away of the bone that needs to go. And so you have this trend of a reduction in your bone mineral density. And if you are exercising, even walking regularly, you will be at risk of injuring your bone to the degree that it might in time fracture, and that might be called a stress fracture. And you have a huge spectrum of these injuries, starting from just sort of inflammation and irritation of the bone. But if you are consistently walking on or exercising on that bone and it doesn't have time to heal, particularly in the absence of available estrogen, which could really speed up the healing, it may go on to fracture, and that can be, of course, extremely painful, but also can take a long time to recover from. Often something that I see is that women might present to, and this is not all, I must say this, but may present to clinicians who haven't considered the role of estrogen in bone health or in the development of this injury. And so their injury may not heal quickly. It may be a long time until the cause, or the root cause is discovered and managed. And of course, the management can be quite complex because, of course, for some people, the not being able to meet the nutritional demands of what your exercise requires can be associated at worst with an eating disorder. And so it can be extremely challenging to manage. But yes, I've learned a lot over time of how to do that sort of sensitively and realistically, really, with people. But
I think what's frustrating is how many people present with essentially all of the signs and symptoms of REDS or hypothalamic amenorrhea, where your periods have stopped due to activity, and yet are not tested for it. They're not tested for hormones. They're, the kind of go-to is to put them on form of contraception rather than investigating the underlying cause. And so actually so many women miss out on fully understanding what is actually happening to them. They know they're put on hormonal contraception to prevent or mitigate something, but it's really not helpful when you're just masking something and putting a big bandage on it.
Yeah, and that's really, we need to underline that it's not a treatment for it's not a treatment for low bone mineral density in an amenorrheic state where you've stopped having periods. Often girls and women might be put on the pill or suggested a high dose pill, for example, because of the high dose of estrogen in it, but it's synthetic estrogen. It doesn't have the impact, or it doesn't have the effect physiologically on the bone to increase bone formation. And like you said, it masks the potential return of menstruation, which is a really important biomarker when it comes to energy availability. Some people are also misdiagnosed as being menopausal because, of course, one of the blood tests alongside the low estrogen and the suppressed hypothalamic or pituitary, hormones, is that AMH, or what people might call your egg reserve or your egg count, and that can be really affected in these energy deficient states. But it can look or mimic perimenopause, or be poorly diagnosed, because really, if you looked at the pituitary hormones, it wouldn't be the same. But yeah, it's not that complicated, but it's just something I think that is poorly taught. And I think it's really important that women understand themselves.
Yeah. And when you mentioned at the beginning about having, an anticipated irregularity depending on your age. In fact, if you're younger, we can anticipate that you would have irregularity because during puberty, your whole endocrine system is learning to talk to itself. When you look at every other aspect of puberty, you would say, well, you're not going to look like that forever. That everyone knows that from a skin, from a personality, from a ungainliness, teenagers are exactly that, spotty, moody teenagers. We don't expect them to stay like that forever. Nobody looks at a moody teenager or a spotty teenager and says, it's a shame that this is how you turned out forever. And yet when it comes to irregularity in your menstrual cycle, it's like, we better fix it, rather than and putting somebody in that immature state on something that is really, going to alter their perception or reality of their menstrual cycles. And when you're put on hormonal contraception at a very young age for heavy menstrual bleeding, irregular bleeding, hormonal acne, there is no time in your life, and this is what we see through our data, that is a good time to say, you know what, today's a good day to get that back. And so people stay almost imprisoned by the fear of their symptoms on their form of contraception for decades, until I, okay,
sort
maybe
of
I need to have a baby.
it's kind of poor prescribing in the sense that these things should be, followed up, and of course people go on it, valid reasons for them, but I think it's about true informed consent, and I think that's the missing link, is that typically people aren't necessarily informed of those additional considerations, particularly if they're athletes or exercisers, where energy availability might be an issue.
Okay. I'm going to talk for a second about just working with your menstrual cycle. We did show this earlier, but there are ways that you can really work within your menstrual cycle in terms of movement, in terms of your energy availability. Twice now we spelled menstruation wrong in this discussion. Nobody judge me.
I haven't noticed.
Apologies if anyone's looking going. But when you see the dramatic difference in your hormones, especially we've spoken at length about the importance of estrogen and progesterone and the impact they can have. They even impact how much we want to eat, our metabolism. And so it's really important, I think, for a lot of people to understand how to work with your menstrual cycle, rather than treating every day as if it's the exact same, treating your recovery, your energy levels, your optimism. To me, I always say everyone should really optimize themselves for ovulation, because from metabolic, from an endocrine perspective, when you have that peak of estrogen, everything's working in your favor. You are, when I say it has links with your cardiovascular or neurocognitive, what that equates to is your focus is sharper, your cognition is greater, your sleep is better, your metabolism is different, because of estrogen linked to your skin looks good. Mother Nature wants you to procreate. She's going to make you as attractive as possible. And so what's amazing is when this goes, we forego the kind of natural, and when we also kind of don't have a natural cycle that we can track, it lets you realize how much of that wave that we could ride in our favor, as opposed to standing in the water like this, getting hit by the waves of your menstrual cycle every single month.
Yeah, I think we've had a few years of this discussion really coming to the fore, and I think what's fantastic is people are having conversations and becoming aware of the fact that there might be, for them, different realities of their experience of being themselves, not just in day-to-day life, but also when exercising. And so the way I like to think about this is not necessarily in regard to performance and using this as a performance enhancement tool. It might be, but it's very rare that even any athlete would, and I'm going to use the technical term, which is periodize, which is basically cycle through a training program on an even monthly basis. It's very unusual to do that. And it's usually done on the basis of symptoms, problematic symptoms that impact recovery and availability to train, rather than in consideration of, say, okay, in the mid-luteal phase, we're going to really bash out heavy strength because I'm really going to get a really great adaptive response in the mid-luteal phase. We don't have that evidence. And also, I think it would be quite technically demanding for anybody to write out a program according to their menstrual cycle. However, what I do say is it's really important to track if you are finding your ability to train and your engagement when you are exercising, or even your motivation to even do it in the first place, if we're thinking more on the health side, is impacted on a cyclical basis. So tracking is a fantastic tool, and you use menstrual tracking tools like even a journal, but like it could be an app, whatever you want.
It's gonna be an app. There's
gonna be an app because
this app.
I'm sorry, it's gonna be an app. But it's really great way of highlighting any recurring symptoms so that you can be a little bit more proactive. Okay. You need at least 3 cycles worth of data to be able to pick up a recurring theme. And for you, but you know, a really common picture that I see is premenstrually, maybe though 5 days, 3 to 5 days premenstrually struggle bus. First week of menstruation, similar. And then we're like moving towards feeling better by mid-cycle, and then it's kind of and then downward. That is not everybody's experience at all, but it's a
Some people
one.
feel terrible for their whole cycle.
Some people feel dreadful for their whole cycle.
Some people don't even notice any change whatsoever.
Tracking doesn't help at all. Nothing. There's no pattern. But I would say, you know, if you're going to think about the science in that premenstrual phase, progesterone is really cancelling out all the wonderful stuff that estrogen is trying to do. But it's good for your sleep. And it keeps you slightly calmer. Maybe not so great if you're doing something that requires a lot of coordination, if that is in fact going to be a cause of problem for you, that phase of your menstrual cycle. Not everybody.
Okay, speaking of phases and how you can do it, I want to quickly move because
yes,
I just realized I actually thought we'd only been talking for 20 minutes, and I realized
I'm sorry
for a lot longer. So I want to have a quick mention about nutrition. The person who wrote menstruation clearly has a problem with how to spell menstruation, so I'm really sorry about that, one of the team. There's a few questions about, you know, certain things that we can eat during our menstrual cycle, or to mitigate the impact of lower or higher hormone levels. I will say that as part of what we built at Hertility, when you do your test and find out your blood results, and I told you we coded over 54,000 clinical scenarios. In addition to that, we also looked at, and it's the most overlooked but acutely studied area that we put into the report that you get when you get your hormone results, is that we looked at all of the different things that could cause your hormone, any one of your hormones, to be either elevated or deficient through 5 different parameters: reproductive conditions, non-reproductive conditions, medication, diet, and lifestyle. So anything that could be causing your hormones to be elevated or deficient, we account for in all of those parameters. So we ask you whether, if you've told us any of those, we also give advice in that section as to how you can mitigate a higher or lower where possible. So that's just my plug for how it's the part of the report that people don't read, and I'm like, please read it. We put a lot of work into this. So here are, I guess, some of the lists of some of the things to eat during your menstrual cycle. The reason I'm hurrying, Amal, is not so we don't talk about this. It's more so that we can get to some of the questions, because there's some amazing questions here that we're essentially at the end of the talk. The remaining questions we can answer, the remaining slides we can answer in some of these questions. But if you want to just, we actually spoke a little bit about contraception, ovulation, and sport already. So maybe you want to talk a little bit about that. We've spoken about estrogen and progesterone already.
I think it's really important to understand that hormonal contraception is varied. So you've got contraceptive pills, implants, injections, rings, coils, all kinds, patches even. Most commonly, people who, so athletes are typically using actually Mirena coils, or the combined oral contraceptive pill. So they work in different ways, as this slide explains. I want to just touch on the combined oral contraceptive pill. So synthetic hormone, and it suppresses your sort of natural hormonal pathways, as we presented earlier, from brain to ovary and beyond. And this will have an impact on the physiology of your reproductive tract even. So beyond suppressing ovulatory function and ovulation, it will change the environment as well within the reproductive organs. In suppressing hormones, it's suppressing your menstrual cycle, the cycling of those hormones. And so when you have a break, if you're having a pill break, you're having what's called a withdrawal bleed, and you're not having a true menstrual period. So it's really important to remember that. However, what we do see in cases of energy deficiency is the ability to even stimulate a withdrawal bleed is absent, because essentially there's not enough proliferation at the endometrium, and so you might not even bleed when you're having a pill break, and that can be a subtle sign. I will always encourage people who have suspicion of, or have a case that's suspicious of REDS, to come off the combined oral contraceptive pill. We also can't do your blood tests accurately because of that hormonal suppression, so it can be really hard to give.
If anyone is on hormonal contraception at the start of the journey, we say, look, you're better off coming off for 3 months before testing, but we can still test your thyroid and your ovarian reserve. And we do caveat the fact that your ovarian reserve can be suppressed by contraception.
And luckily, you know, there are some people who might
We're doing a contraception study at the moment if anyone is thinking of coming off contraception. So please let us know if you're thinking of coming off contraception. We're doing a test because we really want to find out the answers while you're on it, when you're off it, and following you up. So if you want to contribute to the very much needed research, please let us know as well.
Brilliant. Progesterone only pill, Mirena, Ilena, copper coil, what else? Those, we can do your blood tests, but again, you're not necessarily going to have that biomarker of a menstrual bleed to know what the regularity is like, and we know that regularity is a lovely marker, at least, of ovulatory function. The one other comment I want to make is about the injection. If you are very active, it's crucial to know that the injection actually has a possibly negative impact on your bone mass. And so if you're a regular exerciser and something like impact activity like running, lots of jumping, so dance, that kind of thing, or you already have low bone mineral density, or have had a stress fracture in the past, I would encourage you to think beyond the injection. But of course, there are many other reasons that go into considering what type you go on.
Okay, amazing. I'm going to obviously suggest, I genuinely believe every woman should understand their hormones. It's not because I started a company that is about testing your hormones, your symptoms, everything about you. It's because I was really frustrated as an academic, a scientist who has dedicated so much of my life to understanding reproductive science, physiology, anatomy, endocrinology, and then feeling like, how is it that this most fundamental impact that this plays on our day-to-day lives, on our overall health, we don't have access to answers about? So please do a test. Please book a fertility advisor consultation. We have a full team of gynecologists that you can speak to about. Amal, if you have like a minute to pick your favorite question, this really, I can't believe we were talking for an hour, and there are so many questions, and I'm actually...
They're really fantastic.
It really is testament to how just important this is to so many, and the level of questions that people ask. So many of these questions we can actually answer through our test. We screen for 18 of the most prevalent conditions with between 98 and 99% confidence. We have a full data science and machine learning team that have just come back with those results about the predictive power of this test, and that will give you a very informative discussion about everything afterwards. But Amal, if there's any questions there that you want to get to, and if anyone else is willing to stay on, we're happy to answer for you.
Yeah, I think I just want to touch on, because obviously we haven't really focused on fertility precisely. But there is obviously a question around exercising around IVF. I think the considerations when you're trying to conceive, of course, we are all going to do as much as we can to ensure, our physiology is as optimal as possible. And so just, I'll go trying to conceive first. We talk about the rate of change in what you're exposed to from a stress perspective on your body. And of course, at one end of the spectrum, when you're engaging in vigorous or high intensity physical activities, it is a physiological stress. If you are conditioned to that, regardless of the intensity, if you're conditioned to the amount of physical activity you're doing, you're meeting or surpassing the energy requirements of that activity, you're meeting your energy needs, and you are not restricting your nutrition. And if for any reason your diet has to be restrictive, and you do a lot of activity, I would really consider, if you're concerned, speaking to someone about that who's a specialist, and making sure, particularly if you exercise a number of days a week, at least, up to 5, for example, and long durations, high intensity, it's really important that you are not in you're not in an energy deficient state. As long as you're conditioned, you're recovering well, including your nutrition, there is no reason for you to change things. And there is no evidence to support that even when the formed, conceived blastocyst is implanting into the endometrium, that exercise should have any impact on that process. And even in early pregnancy, there is no evidence to support exercise when done in those in that kind of way, where you're meeting your energy needs and you're recovering well and you are conditioned to that exposure. There's no evidence to support that exercise is a cause of miscarriage even. So we know exercise is so fundamental to health. It's fundamental to health of mum and baby in pregnancy. So I always encourage continuing, just making sure you're meeting those energy demands. When it comes to assisted reproductive therapies or technologies, and IVF being one that's been mentioned in the comments, in the questions, would you be surprised if I said we don't have any evidence, really strong evidence? We did a study looking at the exercise practices of women undergoing IVF and the information they were given by their fertility doctors, and whether or not that information they were given by their fertility specialist, sorry, not necessarily doctor, influenced their physical activity participation, and whether or not any change had an impact on, or any participation had an impact on, their pregnancy success rates. We saw that typically women undergoing IVF did reduce their activity intensity and volume, that the advice they were given by a fertility specialist didn't change what they did, and the physical activity didn't change their pregnancy success rate or their pregnancy outcomes. Obviously not huge numbers, 100, but decent and enough to keep plugging away at this. I would say, again, just think about the mechanism.
Healthy levels of exercise, not.
And unhealthy is what you're not conditioned to and what you're not matching in terms of nutritional demand. It's not balanced. If you're conditioned, your body's physiology will keep up.
Yeah.
But in terms of IVF, it's the implantation, I think, that people are concerned about. The guidance currently is go by what your fertility specialist advises you, because there is no other better guidance at the moment. But around sort of stimulation and egg retrieval, it can be quite uncomfortable. So doing as much as you can for health is fantastic. There is no evidence to suggest that the outcomes are going to be affected. But again, I would encourage you to have those discussions with your fertility specialist.
There's a bunch of questions about how to get involved in our research. So
Nice.
please email us. We do have a research page on our website, but if you want to become involved in any of our research, we have many different research studies. We are begging somewhat people to participate in just our ongoing collection of valuable research. So you just email research@hertilityhealth.com. and we can share that with you afterwards when we send, we can send the email for you to contact after once we send around the recording as well. Amal, thank you so much for giving me your evening, your expertise,
Oh,
and your endless knowledge on this subject. I honestly think we could probably talk for hours, and judging
absolutely.
by the questions, we should probably do a part two, just to answer
Just to
questions.
go through the questions. They're
Yeah,
brilliant.
exactly. So I actually think what would be amazing to do is to say to everybody what we're going to do is we're going to look through all of the questions. We're probably going to stratify them according to the different themes that you've asked for, whether it's exercise, whether it's PCOS, whether it's fertility treatment, whether it's pregnancy loss. And really, we take all of these things really seriously because it gives us an idea of just the types of questions that all of you have. So trust me that we will come back with another webinar to answer some of these questions. I've volunteered your time already, but
No, I think it's necessary having seen them. It's good.
ex exactly. We'll definitely do part two with all of the answers. And thank you for everyone for giving us your evenings. We have a code if anyone is there to use it. It's exercise 20 and it's only valid till the 30th. So it's only valid for the next few days. So this is a special discount code for £20 off a fertility test, which is in capitals exercise 20. If anyone is interested in that, it's only valid until the end of the month. So now is your chance. Empower your health and get some answers about your body, and hopefully we'll be able to give you further answers in another webinar. But I appreciate everyone joining, especially Dr. Amal. And
Oh, thank you for having me.
thanks. And we'll see you for part 2, 3, and however many more that we will do to cover these, to answer all these questions. Okay. Thank you, everyone. Take care. Thanks, Dr. Amal.